over the last 40 years or so, whether if it's around preventing new infections, access to testing and treatment, and all of the achievements are certainly in the right direction. Well, I think the question we're asking is this enough? Well, certainly not, especially if the objective is to end AIDS, end inequalities, and end epidemic. And the word N is sometimes used loosely here. And well, there's many other challenges that remain. For instance, the need for effective interventions for stigma reduction. That's to improve prevention, treatment, and care. There's also poor medication adherence. And if you factor all of these, they're all related to poor health outcomes. So there's other pressing challenges as well and priorities. We've got, for instance, COVID-19 with the new variant in circulation, which could potentially threaten decades of hard-won developments. And somewhere I've read a few days ago, as high as 75% of HIV services in many countries have reported disruption during the pandemic. So clearly, there are existential threats and challenges. And what we're here to discuss how technology and digital innovations can support the fight against HIV/AIDS. So what we've done together is we've put together 5 speakers here that would just showcase some of the work, and particularly around leveraging technologies to end inequality, end AIDS and epidemic. So before we get started, I want to very quickly just go through the house rules. That shouldn't take long. I'm just going to share my screen. Here we are. These are very typical house rules, just to make sure the 2-hour session runs as smoothly as possible. So as the moderator, I'll coordinate the session. Could I please ask everyone to mute their microphones at the start, okay? And just make sure your video is disabled. The speakers will introduce themselves at the beginning before they start their presentation. We will have questions after presentations, but could I please ask you to submit them via the chat? Whereas there will be opportunities at the end for you to ask questions. You can unmute yourself and share comments and contributions. So these are the housekeeping rules. And just a quick summary of today's agenda. We've got 5 speakers, as I said. We've got the first speaker, Shola, who's going to be talking about smart HIV solution, followed by 4 other speakers, Joshua, we've got Dr. Ebika Kennedy, Mosala, Seneko, and Emmanuel. And at the end, the last 15 or 20 minutes is dedicated for our Q&A session. So without further ado, it's 2:05. I want to get started and leave the floor for Shola to give us a talk on smart HIV solution. Stop sharing. But before we get started, actually, we have a poll, a very quick poll that we're going to be conducting. That's Antonio going to, if you can get started with the poll. Here we are, a very simple question. To what extent do you agree that digital innovation is a need to support the fight against HIV/AIDS? So we've got about 30 seconds to a minute, I suppose. The vast majority so far is strongly agree and agree. Both are creeping up. Okay, there's a bit of 50-50 split there. Okay, what we're going to do is we'll also repeat this question at the end and see whether if there's any difference, whether if your perception to digital innovation in terms of whether if it supports the fight against HIV/AIDS changes. Okay, thank you for that. Shola, okay, I'm going to stop sharing. I think you can start sharing your screen.
Thank you, everyone who has joined. I just have a few slides, and this is, I need to introduce myself. I'm Shola Diemi, and I'm a co-founder of Smartlytics with Aaron Demir. I'm not going to spend too much time on this slide. Behind us is a team of, different experts. Like people say, it takes one man to invent, but a team to innovate. And apart from the team, we also have a group of scientific advisory group that advises us on, on science actually relating to HIV. Just to say that this event is put together by Bohemia Smartlytics, and every speaker has no financial interest or relationship with Bohemia Smartlytics. The Bohemia Smartlytics has not received any funding from anybody. This is a company that is self-sponsored by the co-founders. Having said that, just to set the ball rolling with some introduction, I'm sure most of you know this data even better than I do, but one thing we need to realize is that even if there's a vaccine today, we are stuck with 38 million people living with HIV. As we can see, over the last 5 years, the population of HIV has been steady, which means this could be due to reduction in infection and people living longer. But what we can agree on is that even if there's a vaccine, we have 38 million people to take care of. And we thought, why is it that the uptake of digital innovation in HIV is really limited? So we went ahead and do a small study in HIV patients and stakeholders worldwide. And what came out is that every stakeholder needs one form of support or the other. Of course, the need might be different depending on the stakeholders, but everybody within the HIV field needs one kind of support or the other. And when we presented the concept of our solution, 93% actually said they will use it if the solution were to be available. At that point in time, it was just a concept. The development had not started. And we can also see that there is a lot of people feeling positive about the solution and ready to recommend it at that point in time. And what is the solution? The solution is a digital innovation that tends to identify, all the stakeholders and meet their needs on the same integrated platform. So during the course of our research, we identify different stakeholders based on the different needs they need. We decided that we need to support each and every stakeholder. So for instance, we want to focus on managing HIV patients, but we need other professionals to support that. We need the managers who manage HIV services, the clinicians who manage the patients, and the researchers, the clinical researchers and trialists who want to test new innovative medication. So that's the concept of our solution. And what we have is a solution that addresses the needs of every of these stakeholders. We've got the Smart HIV Clinician, which is a decision support tool to support clinicians, not to replace clinicians. And the difference between this tool and anyone available is the fact that we are not modeling, we are collecting evidence, available evidence, and delivering it in an easy to use dashboard, which supports patients in clinicians in the management of HIV patients. We also know that because HIV patients are growing older, this comes with a bit of complexity in terms of managing their disease because they are presented with other comorbidities. So these decision support tools provide every evidence available that can make prescription or medication tailored to an individual patient. And we have the Smart Chat app. This is an app that actually empowers patients. Because HIV is now a chronic disease, and we need to empower patients to be able to take certain decisions and also to be able to collaborate with clinicians in their disease management. we've developed the Smart HIV Manager, which is a planning decision support system, which helps policymakers to identify needs so that before they roll out policies, they can test different scenarios and the impact it will have on the different paradigms. I want to mention the Smart HIV Trialist. Because we have the Smart Chat app, which patients are using to manage their daily disease, we also ask if they are willing to be contacted for clinical trial. And we know the kind of disparities in clinical trial enrollment, especially where the burden of disease is felt, the participation in clinical trial is really low. So trialists can contact patients who are interested in participating in clinical trial, and they will also have access to innovative therapy. We know that in some countries they only have a handful of medications to choose from, but by participating and enrolling patients in clinical trials, they can get access to innovative medicine. We also don't want people to this is an integrated technology, but we know that people already have existing systems like electronic medical records. We have a platform whereby we can integrate whatever existing system you have to our Smart HIV solution. So you don't need to do away with the existing system. We can integrate that, and that's why we have the HIV Smart Lytics, because on top of that integration is a visualization platform for you to do analytics. And I mean, looking at how our solution fits into the digital ecosystem stakeholders, we can see that our Smart HIV solution actually supports every stakeholder in the digital ecosystem. There's no one that is left behind, because the app actually sits with the citizen and the patient, because the app has, apart from connecting to the clinician, they can also connect with their body. We call it body because everybody has somebody to support them through whatever they are going through. A body can be a parent, it can be a best friend, it can be a partner. And we also have opportunity for lab results to be communicated via the app and for refill to be dispensed so that a patient can pick up refill in nearby pharmacy rather than going to the hospital and wasting time. And also, by waiting for pills in the hospital, it also opens the door for stigmatization. Like I mentioned before, the existing systems can also be integrated with our solution. So you are not doing away with your existing system. And the app is actually is available for download, and everybody can download it. It has 3 profiles: the patient, the clinician, and the body. The clinician can be any healthcare professional. And also we have a disclosure feature whereby patients can disclose their status to who needs to know, and the app walks them through a process of doing that. So the app is available on both Google and the App Store for download. For this talk, because this is just introducing the solution, we are not doing any demonstration. However, we have an opportunity at the inaugural conference on public health in Africa, which is organized by the African CDC, and they've agreed to give us a slot as a side event to demonstrate the Smart HIV solution. And we will be sending out a link to this webinar very soon, so that anyone who is interested can come and see how this digital innovation works in practice. And that is it. Thank you very much, everybody, for listening. I don't know if there are questions, immediate ones, or they can wait till the end.
You could please, if there's any questions, you're more than welcome to write it in the chat. But there is one question, Charlotte, about the app here. We've got one person asking, is the Be Smart Chat app working in Uganda?
Yes, it's working everywhere. There's no country where, because in fact we have some focus group in Kenya. So I think if it works in Kenya, it should definitely work anywhere. So yeah, it's available.
We've got someone who just said on the chat, in a country like Africa, let's take Nigeria as a case study where the digital awareness and knowledge in remote areas how can they really get across to solve their challenges? You might want to talk about some of the case studies in Nigeria.
Yeah, actually, we've run two focal groups in Nigeria. One in the urban center and the other in rural setting. And we've got amazing feedback about this because we deliver this app in an easy to use way. We use things that people can relate with. Traffic light systems, everybody knows that when something is red, it's not really good, things like that. So we've developed it in such a way that it's easy to use. And it also gives us we also have, it's very flexible, it's adaptable. We can easily adapt it, to any patient population. So if a center is interested, we can look at what kind of patient attribute they have, and we can actually tailor it in no time, seamlessly to the patient population.
Thank you, Shola. Do you want to? We've got another couple of minutes. I can take any further questions. Do you want to just mention a few words about the feedback you've got from Nigeria, some of the users?
Yeah, I think one of the amazing feedback is that it's a one-person story. It's the one that I readily remember. There's a lady whose phone could not support the app, and she decided that she was going to actually sacrifice other things to be able to buy a phone because of the impact the app is going to have in her daily life. And one of the things that she enjoys very well is the daily motivational quotes that we send just to liven things up early in the morning at 9 a.m. You get a daily motivational quote. And the fact that you can also have appointment reminders, medication reminders, and in a world where any kind of medication can be bought over the counter, you can check whether the medication, the co-medication will be interacting with your HIV medication. As we know, this is one of the reasons why clients are difficult to retain on therapy. So this is one story, but there are many other stories too, which are very motivating.
That's brilliant. Thank you, Shola. We've just got another question, but I want to press on. But hopefully at the end we can discuss about this. And the question is, let's not forget, it needs to be rolled out by Ministry of Health and implementing partners. So how are you going to engage them in Uganda? Because I have seen it will have improved on adherence. Yes, this is something we might want to touch at the end. So thank you. I've saved this question somewhere at the end. Okay, brilliant. Thank you.
All right,
I think we need to press on. We need to press on. Thank you very much for that, Shola. Our next speaker is Joshua Ocheng Olio. Joshua, do you want to start sharing your slides? You're muted at the moment.
Thank you so much.
Thank you very much, Joshua. If you could start by introducing yourself, okay? And Joshua's talk is on U equals U and its implication for HIV combination prevention. So the floor is yours, Joshua. Thank you.
I am a young person from Kenya, age 24 years of old. I am from Kenya. I've lived in this area for the last 21 years. So that you will see. And I will start by saying I'm very happy to join you today, being the World AIDS Day celebration. We celebrate my resilience. We celebrate people living with HIV who have resilience to adherence, as well as we also remember those who have departed from due to some comorbidities that have resulted from HIV. Without much further ado, I want to share my screen. Just a minute, allow me to share my screen. I'm going to take you through a presentation. I know I'm going to take you through a presentation about U equals U, implementation and its implications.
Sorry, Joshua, we can't see the screen. Have you shared your screen?
Just a minute, I'm
okay.
sharing the screen. Yeah.
Or would you like me to share your screen?
Minute, my laptop is just taking time to open, but I've already
Okay.
opened it. Allow me to share the screen now. There it goes. Right, I'm also working on the audio. I hope now you can hear me loud and clear. Let me put on the slide session.
Yep, we can see the screen. Thank you.
Okay, thank you. So just as I said, I'm Joshua Okiomolio. I'm going to take you through the view and its implications for HIV combination prevention. I know these are new scientific approach that the communities living with HIV has really taken into much consideration when it comes to the gains and efforts towards HIV prevention messaging. And so currently 30 years and I know now almost 40 years, the globally the HIV pandemic has had a critical need for effective prevention strategies. And I will really articulate that there have been a lot of interventions that have been done, but these interventions really need to be implemented with a high levels of coverage, looking at various populations. So U equals U as a new component of the HIV combination prevention really wants to look at people living with HIV who have taken their medications daily and have durable suppressed viral load cannot transmit HIV to their partners. This is a conversation that has been held within several years. People have been asking themselves, if my partner is living with HIV, is he able to transmit the disease or not? And therefore, this really encourages people living with HIV like me to have a good adherence that can make them live healthy, live longer, and prevent STIs, which is that including HIV. So scientifically proven, it has been proven, and I know we have overwhelmingly agreed for the use of U implementation approach, and that includes that we are able to really define that U equals U is really working. I know very many countries have really decided to take up their roles to discuss about U equals U, and that includes Kenya, where which did their launch on the U equals U campaign 2 months ago. So UNAIDS tries to look at some of the definition of combination HIV prevention. I know people will start asking, what is this HIV combination prevention? Yes, we talk about HIV prevention, but then there are several ways that we really define this. So UNAIDS 2010 report really articulates that it's a strategic, simultaneous use of different classes of prevention activities. These may be classified into three, that includes biomedical, behavioral, and social or structural. So it means we are not leaving out other forms of prevention. And that means we don't have a prevention that is really looking towards 100% not transmitting HIV. So we are looking into a multi-component package, which really takes in the key considerations of evidence-based biomedical, behavioral, and structural intervention. So it must be appropriate, acceptable, and deliverable to populations with high levels of coverage and adherence. So one of the key things that really looked into these packages includes the address risk factors at individual, dyadic, sexual, or needle sharing network and communities, while taking into account the epidemiologic context. So this slide really tries to look at an overview of the HIV combination prevention, which currently people are talking about when we want to look at ending HIV in 2030. So this slide you're seeing here is a slide trying to show us very multiple disciplines and approaches that have been used to illustrate the HIV combination prevention. So you see the HIV prevention at the central core, and then we have biomedical interventions. This includes some researches that are being done currently.
Then you see the structural interventions. Then we have the community interventions. This includes the messaging surrounding HIV prevention. Then we see individual and small group interventions. These also include a few of the messages, but also take into considerations people living with HIV being in support groups, people having different discussions at various levels. Then we have HIV testing and the linkage. Yeah, one of the ways to end HIV is we must test and we must link those who are tested positive. That will give us a way out to really encompass that we are able to really think about having our population tested, having people get into ARVs, and then that will also focus into the 95 strategy that we are talking about. So if you look at this arrow really gives us the three key measures, but then we realize that combining interventions is not enough. And then that means there needs to be a lot of work to be done. And that is why you see the U equals U concept is coming in, because it's coming in to just integrate these few multiple disciplines and approaches that have been always taken through in the fight against HIV. Sorry for that. I'm trying to get to the next slide. Okay. So there are very many forms of HIV prevention, and these forms are what is referred to as HIV combination prevention. One is the use of condom. I know we have a lot of health promotion issues when it comes to condoms, and we have always wanted people to use condoms very correctly. There have been a lot of demonstration of condoms in different countries, including Kenya, where I stay at. And I know we have developed very many interventions on how to talk about condom use, condom demonstrations at various levels within different countries. And one of the key things is that it's given that 60% HIV prevention is articulated within condom. That is why we are still talking about the HIV combination prevention. So it means 40% is left for the other issues. Now, apart from condoms, there is the pre-exposure prophylaxis. That is, we call it the PrEP. This is also a new scientifically proven intervention that really came out some time back. And there is a call that we need to put and scale up the partners of people living with HIV to really get into access to PrEP, which is an antiretroviral prophylaxis, so that they may not be able to transmit HIV or get HIV from their partners. So the PrEP is given to HIV negative patients to act as a preventive measure so that they may not be able to transmit HIV. Besides the PrEP, there is a post-exposure prophylaxis. And post-exposure prophylaxis are given to those who have had an exposure, and it's given after a sexual exposure or an exposure to the HIV virus. And that is what makes it different from the pre-exposure. Pre-exposure is given before you get a contact with somebody living with HIV. And that makes their difference. And mostly post-exposure prophylaxis is also given, it's given with some duration, but the pre-exposure prophylaxis, you may take it as long as you are at risk of HIV infection. So that brings the clear, distinctive, different arguments about the pre-exposure and post-exposure.
So Joshua, you've got 5 minutes for your 15 minutes to be up, okay?
Okay.
Thank you.
So then the last form is the U equals U that I will really talk about in the next slides. So what you're seeing here are some of the few studies, and I really picked this slide from the International AIDS Society Conference 2018 presentation. And this was trying to look at some of the studies that really have articulated the issue that treatment equals to prevention. And that's why we talk about we talk about the U equals U. So you look at this presentation very well. It gives out some of the clear studies that have been done around the world that really have made us to accept that U equals U is perfectly said. And that means 100% of viral load suppression. People will not transmit the virus for their partners. So what you see is a presentation on HIV status neutral prevention and treatment cycle. So this has been all along a common way of discussing HIV prevention with the major focus not looking at the U equals U concept, but U equals U concept is now coming in to add into all these. And we will say HIV prevention is equals to treatment. So why U equals U? That is something that people will normally ask. Why am I advocating for U equals U? Number one, it will enhance stable relationship among the discordant sexual partners. If my partner is living with HIV and I know he or she is suppressed, then it means I will still have that motive to continue the relationship. Number two, stigma has been an issue. And of course, when we talk about these, people associate HIV with sexual contacts. And therefore, there have been issues, wrangles with stigma-associated concerns that now when I'm having a partner who's living with HIV, he will be able to give me. So people don't want to relate to people living with HIV, and that leads to stigma. Number three will be improves the quality of life. Yes, when I'm suppressed, I really want to continue being suppressed. So I want to be healthy, and that leads to that. And then we have a normalized spousal and partner sexual relationship. So spouse, because most of the time arguments on HIV becomes very difficult for people, especially at that point when one is living with HIV. It really tends to want to learn, it really tends wants to live, wants to have a breakup. But when now they have these discussions and then they see clearly U equals U really works, then it doesn't bring a lot of abnormal discussions, but it normalizes several discussions in the family. So very critical role, technology in the fight against HIV and now the global AIDS strategic framework 2021-2026. People are talking about the vision 2030. People are talking about sustainable development goals, and HIV is also one of the key things. And we see people talking about leveraging technology. So in the U equals U concept as well, we also need to start thinking about leveraging this technology to really focus on these key elements. And as given by the first presentation by Shola, you are able to see some of the issues articulated on the BS Mart app concerns. And so this also gives us a way of thinking, how can we use the technology to really monitor various parameters, monitor disclosure, monitor access to medicine, monitor support engagement, monitor knowledge hub, enhance the knowledge. How can we enhance the knowledge using the digital platforms? And how can we enhance our therapy compliance, that in layman's language you call adherence? And how can we connect with clinicians that we call, that we really want to see our medical records being done digitally? And I know several countries are trying to leverage on the technology. In Kenya, where we are, people are using the electronic medical records, and we are coming out from the analog way to leverage some of these key interventions. And that means U equals U is not left behind. Thank you so much for having me for this discussion. I'm very glad to be here. I am part of the Empower for Change advocates in Kenya. You can always follow us on Twitter at _Empower for Change K. Thank you, and back to you, the host.
Thank you very much for this invigorating talk, Joshua. Really appreciate it. In terms of the timing, can't be any more perfect. Thank you. I think in terms of U equals U, it certainly is an exciting breakthrough in our understanding of HIV transmission risk in patients who are virally suppressed, and a proven concept in HIV prevention too. We've got a couple of minutes, 2 to 3 minutes for questions. I mean, if you do have any questions, please write it down to chat. And in the meantime, while we're kind of waiting for anybody to ask a question, I think I've got one. Joshua, on slide 4, you showcased the HIV prevention combinations, which included, if I'm not wrong, biomedical interventions, community interventions, structural interventions, and so on. To what extent do you think this is successfully executed and implemented in Kenya? Are there any lessons that can be learned from Kenya here?
Thank you so much for that question. One of the key things is, yes, Kenya is gaining into the HIV prevention. And one of the key success, I would say, is we have been one of those countries who have come in very fast to really comply with the HIV prevention guidelines that are given, that are really recommended by WHO. When the U equals U came, it really came as a component of the global sphere discussions. But then Kenya is one of the countries that also decided to launch the campaign. I know there are some countries that have not decided to launch the campaign. And so we are really up to the task to really have that HIV prevention. Number 2, Kenya has also so many organizations that are working towards various HIV prevention interventions. So we really want to take up the space so that we can have a lot of forums to really talk about HIV prevention. Thank you, and back to you.
Brilliant, thank you, Joshua. I think we've got one question over here. It says, did U equals U, is it concerning married couples or those having HIV only? I'm not sure if that's the question.
Hey, thank you so much for that. The first thing we'll have to agree is people living with HIV has faced stigma of being in a relationship, sexual relationships, because we know 98% of HIV transmissions are sexually transmitted. So one thing is people are trying to ask themselves, if I have an unprotected sex with somebody living with HIV, am I going to contract the virus? So it means the U equals U concept is looking towards a sexual transmission. So it doesn't matter whether you're married or not. What matters is a sexual transmission. So it means the issue of marriage now comes when you are a spouse, and it means at one point you must have that sexual transmission. You must have the sexual contacts. That is why the married couple comes in. Because if we talk to the young people, then young people don't have married couples. We have sexual partners. So this really looks into the approach of a sexual partner as opposed to married couples.
Thank you for that, Joshua. Thank you. I think we're just in time now for our next speaker, who is Dr. Ebuka Kennedy, a HIV physician from Lagos State University Teaching Hospital. And he's going to, in his talk is on the impact of COVID-19 on people living with HIV, leveraging technologies to reduce inequalities. Ebuka, do you want to very quickly introduce yourself and then you can get started?
Can you hear me?
Yes, we can hear you.
Yeah, good afternoon, everyone. My name is Dr. Ebuka. I'm an ERT clinician working in Lagos State University Teaching Hospital in Nigeria. And I'll be talking on the impact of COVID-19 on patients living with HIV/AIDS and leveraging technologies to bridge inequalities. Sharing my screen.
Okay.
Is it showing?
Not yet. I think it's almost there. No, we can't see anything yet, Ebuka. Yep, I can see the screens and the introduction slide.
Is it there now?
Yep, so on the main slide, yep. Okay.
Okay, yeah. All right, thank you. So the topic is impact on COVID-19 on patient living with HIV/AIDS and leveraging technologies to reduce inequalities. We all know that the World AIDS Day has been celebrated on 1st of December. And then the goal for this award is to see how we can end inequalities as regards patient living with HIV in terms of care and management. And we are all aware that COVID-19, which is the pandemic that happened late 2019, has really revolutionized healthcare and brought in new advances as regarding treatment of patients. And this is my outline. So we're looking at introduction, impact of COVID-19, way forward, and leveraging technology and its advantages, the achievements, and all. So the introduction, HIV remains a public health issue that affects millions of people worldwide. Although the world has made significant progress in recent decades, important global targets for 2020 were not met. Division, disparity, and disregard for human rights were among the failures that allowed HIV to become and remain a global health crisis. Now, COVID-19, as it were, is exacerbating the inequities and disruption to services, making the lives of many people living with HIV more challenging. So what COVID-19 did was a lot of people that needed to have care at the hospital were being restricted because of movement and the fear of contracting the virus. And this ended up disrupting the proper care and management of people living with HIV. The COVID-19 pandemic has challenged clinicians, the public health authorities, companies, and government to quickly develop new capabilities for supporting recovery, maintaining health security, and building resilience. So the digital tool and strategies have become crucial in this effort, and leveraging of technology seek to help by amplifying such digital offerings, facilitating implementations, identifying gaps, and better aligning efforts with needs. So we're looking at the impact of COVID-19 on patients living with HIV. Mothers receiving medicine to prevent transmitting HIV to their babies dropped by 4.5%, and HIV testing dropped by 22%, holding back HIV initiation in most countries. Also, patients living with HIV are particularly vulnerable during the time of COVID-19, and although recent research suggests that patients living with HIV may not be contracting COVID-19 at disproportionate rate, which is hypothesized to be a function of the ART medications. Patients with HIV who are not taking their medications or whose disease is not well managed may be at increased risk of contracting COVID-19 due to having a compromised immune system, and may also be at increased risk of serious death and symptoms. So we're looking at what is leveraging technology. So remember, the topic was the impact of COVID-19 on patients living with HIV and leveraging on technology to reach these inequalities. So what is leveraging technology? This is the use of technology to make significant changes in a particular area. So in this particular area, we're talking about as regarding health and patients living or people living with HIV/AIDS. Leveraging technology also the ability to create increasing value with a stable or shrinking amount of resources, while at the same time increasing the ability to evolve at a faster rate. So technology, we know, touches nearly all parts of our lives, including healthcare, and novel digital technologies are creating exciting opportunities for health promotion along the continuum of HIV care and prevention, especially in the light of rapidly expanding access to this technology. So this image just shows the concept of digital health. We have the ML. So the ML includes use of SMS, using of app, that's like B-Smart app, in order to leverage technology at solving HIV care, prevention, and management. So we'll be looking at certain technology. So there are different technologies used for the HIV and AIDS. We have gamification, where you use use of games to encourage people to learn about HIV. It's being used in social media and several platforms. Just that a game is being created which teaches young ones about HIV care and management. Then we also have telemedicine. Now, the advent of telemedicine in HIV program actually sprung forth, especially in Africa and then in Nigeria, where a lot of patients who could not access HIV care had to communicate with their physician despite distance. So they don't necessarily need to go to the hospital, but then a platform was created so that patients can connect to their physician and make necessary complaints. And really, this has really blossomed, especially in Africa and even all over the world, and has made the disparity or the inequalities as regarding treatment of HIV patients minimal. So this has the primary benefit of this is that it can increase the speed at which someone can access care and then reduce the cost associated with accessing it, such as travel costs. For this reason, it particularly holds promise for the delivery of healthcare, especially in rural areas. So how can technology leverage help reduce inequalities? One, inequality access to trusted, reliable health information. So messaging platforms, for example, as I mentioned, can help to reduce inequalities. Then inequitable access to medical expertise. An estimated 80 million additional health workers are needed to achieve universal health coverage by 2030. Digital tools and approaches can extend the reach and skills of the existing workforce and provide new ways to address this gap. Inequitable access to medical commodities and other interventions. The availability of essential medical commodities such as medicine, including ARV medications, the vaccines, diagnostics, devices, and more has enormous influence on the quality of care. And digital tools and approaches can streamline supply chains and provide better data to anticipate and address supply shortages, that's of the ARV medications and the whole tools for diagnostic when they occur. So it has several benefits. It has benefits to the customers, that's to the end users, and also benefits to the clinicians. So we'll be looking quickly at the future of technology for HIV/AIDS epidemic. So new technologies and new applications of technologies open up a whole range of possibilities for the HIV response with the potential to be extremely effective if they are designed, used, and targeted properly. Although access to basic mobile technology has reached near universal levels, major barriers to internet access still exist. One of the most promising aspects of e-health, which is the leveraging of technology, is the potential for enhancing the integration of HIV services and HIV treatment cascade across provider places and time. So we can see that if we leverage technology, we can actually bridge inequalities. Even though we know there are challenges with internet access and then people accessing healthcare. Imagine a patient, someone living with HIV, he may not necessarily need to come to the hospital if he can lay his complaint using a mobile app or a telemedicine platform. He might not need to go to a facility and then have a long waiting time waiting to pick up his ARV medication. With the use of technology, these inequalities can actually be bridged, such that the patient can easily, access their medications and care, and also communicate with their clinician, even while being distant from a health facility. So for the conclusion, leadership from public, private, and funding organizations can contribute to this ongoing transformation. We need to continue building evidence of health impact, expanding the community of global citizens working on digital health, and promoting the promises of digital technologies from existing inequalities. While not everyone might not have access to internet or a mobile phone, we can work together to create a more equitable system for health and bridge the digital divide in healthcare. Thank you very much.
Thank you very much for that, Ebuka. That was great. Any questions that you can type? I mean, while we're waiting for anybody to type in a question, I've got one. Ebuka, as a ART clinician, I'm sure during the COVID-19 pandemic, it has also impacted your service and your patients too, and which I'm sure because it affects people living with HIV in many ways. You might have missed clinical appointments, the interruptions to HIV treatment and care. I wanted to find out whether if you had to resort to any form of technology to make sure that the care is uninterrupted.
Yeah, thank you very much. During the advent of the COVID-19, it's really disrupted a lot of provision of healthcare services for patients in HIV. So what we did was to find ways to communicate with our patients, and then we got the details because all of them have their own biodata and information in the monitoring and evaluation unit. So we got their data and their information, and then their location, which was very important to us because we know the most important thing is pick up of their area of medication. So we ensured that we communicated with most of our enrolled clients and then linking them properly to community pharmacy that we are close by to their area or to where they domicile. So it was very easy rather than everybody coming together to where they might not be able to access therapy or treatment. We linked them properly to community pharmacy or to certain primary health centers that were close to their area, where they can just easily go there and then pick up their medication. So this was the approach we used to ensure that there was minimal missed appointment and also patients not picking up their ARV medication. So it actually affected us. And then before we could result in bringing up this strategy, it took a long discourse to ensure that our patients at that point in time will not be found wanting in taking their medication. So we used an approach which is linking them properly to nearby community pharmacy, picking up their medications, and then continuing their ARV care.
Oh, that's quite interesting, actually. Do you think this new approach is going to continue as it is, even post-pandemic?
Well, we have to improve, and I think that is why the issues of telemedicine and then use of the app, like for example, the BSmart app provides a more elaborate platform, because the challenge we had was that aside picking up their medications, these are patients, and then they also have complaints, and they will need to interact with the doctors or their caregivers or their clinicians, and also need to run certain tests like their viral load. These were the issues we actually encountered during the pandemic. But then it was just for the meantime, as I said, but with the development of the app and then looking at other ways of leveraging technologies, I believe that we can move forward, ahead while considering better approaches. So the app that's come to stay, that's available for downloads in different platforms, will actually help us, because then it's going to increase adherence for patients, and then it's not going to encourage disrupt in patients receiving care from any facility. So looking ahead, the app and telemedicine will be a better approach in tackling disruption in healthcare, which COVID-19 brought upon us in 2019.
That's quite interesting to hear. Thank you for that, Ebuka. We've got two questions here. Yeah. From Mosela. How many chat applications are out there, because there are none in South Africa? I mean, are there any these kind of applications you're using in Nigeria?
Oh, okay. Currently, the BSmart app is what we're trying to integrate to most parts of the country in Nigeria. So, of course, we're just starting up, and then we're trying to see how we can ensure that patients and patient caregivers and also the clinicians have access to this app. So at the moment, we are rolling out, and then we're creating awareness and seeing how we can implement it right from the Ministry of Health down to users' end. So the app, as it were, as I said, is just a new development, and then we are looking at how we can leverage on it and then reduce inequalities, also encouraging adherence to treatment, and also supporting the patient as it were. So at the moment, there is no global or app all over the country that is being used by all clinicians or all patients. But then we are looking towards it, and that's why the BSmart app, was developed at the moment.
Okay, I mean, just in this context, we've got another question actually. You might want to continue. It says, which of these technologies are more applicable in very rural settings?
Okay, so as I mentioned, we have the mHealth, and the mHealth includes use of SMS. For the rural setting, they might not have access to internet, as I mentioned, and then even to mobile phones or sophisticated mobile phones that could do, the basic, app procedures. So one of the ways, in very rural areas that are having challenges with internet access is the use of SMS. So they can use an SMS that's sending messages, getting their number, communicating with them. Okay, it's time for you to pick up your medication, or this is the nearby community pharmacy. You can pick up your medications. These are the drugs you need to use, or you are eligible for viral load testing. That can actually go a long way, in combating the issues as regarding internet coverage in rural areas.
Yeah, this came up quite often, actually, internet connectivity in rural areas. Yeah, it's something that needs to be embedded within the technology. Yeah, I've got 2 minutes, 2 more minutes. There's a quite an interesting comment that's been made. It says economic inequality remains one of the major obstacles to leveraging technology in the treatment and prevention of HIV/AIDS. The majority of HIV infected people are battling economic hardship. There's a lot that can be said over here in terms of the inequities of the distribution of funding when it comes to HIV/AIDS. Is there anything you want to mention about this, Ebuka?
Well, as I've highlighted in one of my slides, we have issues with economic hardship, especially in areas in sub-Saharan Africa, and then that has been a challenge. It has been well noted. So, moving forward or moving ahead, we can find a way at the end of the day to liaise with the governments or stakeholders or non-governmental organizations and implementing partners to make these applications or this technology provided to them at a very minimal cost, or if possible at no cost. But then minimal cost is safer to say, because then if we're going to reach out to a large number of people that are not even living above $1 per day, and then trying to tell them, oh, you need to have a phone, you need to open this app, you need to do this, you need to do that, they might just not want to, apply themselves in using of that technology. So it can further even increase inequality, because then if you're going to say everybody's not going to use the app because of economic issues or financial constraints by most of the people living in that country, it's also going to create a large, gap in the inequality. So what can be done is through the Ministry of Health and then through the implementing partners, providing this technology to the citizens at a very, very subsidized rate, and then they can gain, access to it.
Yeah, can I just weigh in on this? Because whether you like it or not, I don't know whether economic inequality will ever be eradicated. So I think within the current system, I see a lot of wastage in resources, and by investing in the right technology or the right tool, I end up actually saving costs and be able to provide this application for free for some of these, because they are facing hardship even now. Some of them need to pay for transport fare to go to collect their pills, for instance. On top of, despite all this economic burden, they still need to visit hospital, they need to travel, they need to, either, even for some of them who are working, one of the feedback we've gotten is that they need to take either half day off or a day off just to go to, to collect their pills. So in fact, the current system tends to even impoverish patients, and having a technology that can take away all these inefficiencies will actually save costs and be able to actually, make a bit of contribution to the economic inequality that we are facing. Thank you.
Thank you for that, Shola. Thank you. I'm a little conscious about time. I know we've got 2 more questions. I want to kind of press on. We should have some time to answer these questions at the end. Okay, there's one of them that says, is there a 24-hour response when patients use the app? This is something we can look at the end. I want to move on to our next speaker, Mosela Seneko. Mosela, are you with us? Okay, Mosela is a professional nurse at Dr. George Mokari Academic Hospital, Pretoria, South Africa, and the title of her talk is Evolution of the Health and Illness Continuum, from early days when it started until now, current challenges around HIV and AIDS. So Mosela, would would you like me to share your slides?
I have a PA.
Oh, you have a PA. Okay.
Shola?
Sorry, Ebika, do you want to stop sharing your screen so that we can move this to Mosala? Ebika, are you? Or can Shola could, or shall I could share your slides as well if you want.
Oh, you got them. Okay.
I've got it. Yes, I'm gonna let me share it. Okay, I'll share it. If you can just give me a sec.
Yeah, because I think the problem is on my laptop. I can't find where I saved them.
Here we are. Okay.
Good.
Can
Basically,
you also,
what I wanted to achieve was one thing that we have done is we are always talking about where to from here, but we never look where we actually come from with this epidemic, right? And hence I'm going to talk about how everything has evolved, like the health illness continuum, how it evolved around HIV and AIDS and, you know, drug regimens, interventions, preventions, everything that we've tried to do. All right, we can move on to the next slide. From the early 80s, you know, there was this case that was found in Johannesburg, and it was a homosexual male, and therefore during those times, that's when the stereotype was that this disease is only contracted by homosexual males. And there's a very nice depiction of this kind of homosexuality, HIV stereotype in, there's a series called Pose on Netflix. It was actually quite interesting. And I mean, we are here now and we are aware that it's not about homosexuality and that anybody can actually catch it. And we've now, I think, achieved understanding in how it can be transmitted from the one person to the next. And then in the African continent, in the early days of the discovery of this virus, we had a lot of political unrest, especially in South Africa. We had apartheid, and HIV was pretty much ignored. So there were a lot of people that were dying. There were a lot of HIV and AIDS related illnesses that were erupting, but it was sort of like being ignored, like it was bypassed. And silently, while we were concentrating on apartheid and gaining yes, we can move. And then, you know, with political influence, remember with one of our speakers, we actually discussed how can we hold political leaders accountable for the decisions that they make. So we've also had an evolving political influence on how HIV and AIDS have been intervened with, treated, outreach programs created depending on who was our decision makers. Because remember, we do the clinical practice, we do a lot of it, but we seldom make all of the decisions. So in the early 90s, it's only when Nelson Mandela was president that he acknowledged that, listen, we now have a public health disaster, which is HIV. And still then, not even everybody understood how it was. And it was only then, after 1994, that Nelson Mandela acknowledged it, that there was this grievance response crisis. And then by this time, I mean, there were a lot of deaths. I mean, remember, we had Nkosi Johnson, we had, you know, all these faces of HIV that came out and said they were HIV positive, but still very little about the disease was understood. And the one problem that we had was that by the year 2000, the Department of South Africa tried to outline a 5-year HIV and AIDS plan, but we received very little support from President Mbeki, because he also had different advisors, because he had a group of sort of like AIDS denialists, which was Dr. Peter Duisberg, and they rejected the conventional HIV treatment that was existent at the time. And they instead blamed everything on poverty, colonialism, and corporate greed, which I think was just very biased. A lot goes around the disease on its own. And then, you know, I always say without the government support, like there's nothing that we can do. I mean, we've got all these innovative plans, we've got all these interventions that we want to do as healthcare practitioners, and we've got IT support, we've got allied health, but we need our leaders coming like to the bench. They need to come to sit at the table and do this with us. So without the support, the year plan did not get the funding and everything that it needed. And then that's when, I mean, the infection rate kept on rising, and we had even more deaths. All right, yes, we can move. Yeah, so without the government support, the 5-year plan did not get off the ground as quickly as planned, with few showing up to receive free antiretroviral treatment. Remember, there was a lot of stereotype about what ARVs will do and how people didn't want to take any of it. People didn't want to tolerate the side effects. They didn't want to wait until the drug settled in. The drugs also had, I mean, it was early days, so even virologists and pharmacologists didn't understand the virus very well. So there were treatment regimens that were being introduced that were still on trial, and not everybody was coming in to come onto this trial. We can move to the next slide. And then, yeah, so the other problem was that, as it has been said when I was introduced, I'm a midwife, and one of my goals is to have an HIV-free generation, meaning my goal is for every HIV-positive woman to give birth to an HIV-negative baby. So we have an elimination and prevention of mother-to-child transmission that is currently in place. And, you know, I heard that in Kenya, they have a 95% goal. In South Africa, we're still on 90. We're on a 90-90-90 goal. And then during this time when this was spreading, I mean, women were conceiving, and this is when now there was a lot of mother-to-child transmission. And it soared from 1% in 1990 to about 30% in the year 2000. So that was like a huge pandemic. Okay, political influence continues. Let's move. Yeah, so we had this increasing pressure and the demand of ART treatment, and eventually President Jacob Zuma became president, and that's when ARVs were starting to be allowed to be dispensed at primary healthcare settings and hospital settings in South Africa and primary healthcare. So this just shows that without political support or support from our political leaders, like, we are unable to battle with any disease. It doesn't matter how innovative we get. It doesn't matter what discoveries we make. If we do not have their support, if we do not have their AOK, if they do not fund all these things, then we are still going to be stuck at the same place, and we're not going to achieve any goals. And I mean, our whole topic today is we need this global pandemic to come to an end. And to date, there are still many people that aren't on therapy, and there are very high rates amongst young adults. And then with the recent election of Cyril Ramaphosa, I'm not sure if the economic priorities of this country are enough around HIV, especially because I've got experience in both private and public health. So I have actually seen that, you know, with somebody that's got medical aid or that has got funding, I mean, it's easy for them to go to a pharmacy with a prescription and they just buy what they need and they get out. But there's a lot of surplus that needs to go into public health. There's a lot of support that needs to go into there. So we need a lot of resources, and we have a lot of overcrowding. So this still boils down to we need political support, because political influence says a lot about how we actually going to get anything into place and how we actually going to achieve anything at this current moment. And then going on to populations that are most affected, we have your teenage to young adults, your young people aged 15, and they make up the largest proportion of infected people. So today, as we've been speaking about the Be Smart Chat app, I was actually thinking to myself, you know, I mean, if they're the highest population of people, they've got smartphones, they're on Instagram, they're on Twitter, they're on LinkedIn, they're everywhere. So if we've got an application that allows them in the privacy and convenience of their cell phones, which they hold so dear to themselves. Because I've even noticed, you know, with teenage mothers, after they give birth, they want to take pictures, they want to take selfies, post on Instagram, yay, I just delivered, I have a baby boy, I have a baby girl. So I wouldn't say that there's really that much of a gap when it comes to technology, because I think even your cheapest Android phone in South Africa can download the Be Smart Chat app. I've actually tried it on several different phones that have Android. It's also downloadable on Apple. So, I mean, with the largest population of infected people using smartphones and all over social media, there's, the Be Smart Chat app would actually be a more convenient way of actually interacting in a buddy system to your clinician and the patients being involved actively in their management of HIV. And then obviously women, we make up the highest population. So we account for more than half of new infections. And I mean, obviously then there's a certain percentage of us that fall pregnant and we are also HIV positive. And then, you know, we've got PMTCT protocols, prevention of mother to child transmission, that's PMTCT, that require pregnant women to be tested. So I guess that might be one of the reasons we have a high percentage in pregnant women, because now if you're pregnant, we test you on the spot. It's not, you know, a voluntary testing type of, I want to go in and test and know my status. All right, yeah, we can move.
Marcella, you've got about 4 minutes, okay?
Yes. Almost done. So we've got a couple of successes in the South African battle. We introduced HIV. We've got prevention of mother-to-child transmission with a drastic drop in the mother-to-child transmission. And then we've got a widespread use of prophylactic ARVs. That's your PrEP and your PEP. It was spoken in by one of our speakers from Kenya. And then we have new use of prophylactic medications for sex workers and high-risk sexual behavior groups. And, you know, we've got NGOs in South Africa that are involved in this. We've got VITS RHI, we've got ANOVA, we've got Oram Institute, we've got Rights to Care. There are many NGOs that are involved in this prophylactic ARV medication dispensation. And then we have got a drop in the death rate, because now at least most people that are aware that they're HIV positive are on treatment. And then we have made a huge improvement in getting a lot of people tested. So we have met our first 90 goal in people being aware of their status. And then we're still one of the first countries in sub-Saharan South Africa that fully approve of PrEP and PEP. So that is one of our achievements. And then we have current challenges that we need to face. We still have the big stigma. There are still deaths that can be attributed to HIV. There's still a lot of myths. We still have orphaned children, child-headed families, poor drug adherence, overpopulated healthcare facilities. Hence, I'm saying the Be Smart Chat app can actually help, because I mean, nobody's going to be migrating to a certain institution to go and attend if they've got the app at hand, at their disposal in their hand. And then we still have no cure. So we still have millions of people living with HIV. And we still have new infections every day. And then we still have children that are being initiated on ARV treatment. And this means that we still haven't gotten closer to the HIV-free generation that we desire. And well, in my opinion, as a professional nurse and a midwife, I think the sooner the vaccine comes as one of the solutions that can come into, and then drug adherence. But I mean, we cannot achieve a lot of drug adherence if we are unable to give full context to our patients. You know, increasing buddy systems and peer support groups. Because of this overcrowding, we end up giving a quantity instead of quality healthcare. And then I think we need a revised national strategic plan, and then we need an innovative technology way to combat this current challenges that we have. And hence, I'm saying when this BSmart chat app was introduced by me, by the Smartalytic team, I was like, this is great. This would work perfectly for me. And the technology can prevent new infections. It can improve health outcomes. It can reduce HIV-related disparities, because sometimes we literally treat patients on a quantity, like, are you here for your treatment? Here, go. Are you here for VL? We don't follow them properly. I mean, if I need to see a head count of 120, that's a very huge influx for me as a healthcare professional to actually take care properly of everybody. And then we can achieve an integrated and coordinated way in which we and the patients can work together. So this still boils down to, we still need political support. We still need our leaders to come in on this. The BSmart chat app is, I vote for it. I vouch for it. I think it would make my work very much easier. It would answer a lot of questions that patients sometimes have and are unable to come and ask them. And it would increase, because we don't have enough peer support groups, because the problem is, where would we actually have them? So I mean, on the app, there's a spot for the buddy system, which is actually a very good thing. So we've come to the end of my presentation. Thank you, guys.
Thank you very much for this, Masala. That was fantastic. We've got time for one question. Okay, one question only, just to stick with time. Any questions at all? You might want to write it down to chat, type it in. I've got plenty of questions. Masala, that was fantastic. I mean, you gave a great overview of the chronology of HIV, going back all the way from the 80s to today. And clearly South Africa has achieved so much, but as you rightly said, more needs to be done. And I was quite interested in saying, you know, what could technology do that the current practices fail? Things like stigma, poor drug adherence, you know, you mentioned overcrowded facilities.
Yes. Usually what happens is that you find there's patients in rural areas, so they all literally spend a lot of money to go to one healthcare institution. We've got these MOUs that we have that run 24/7. And then now they are in queue because they've got questions. Now they're in because they experience side effects. And remember, now here I am stuck with a head count of 120, and I'm triaging cases. I'm going to deal with the more severe ones. And, you know, with peer support groups, most of them cannot even afford to travel to these institutions every day to physically be there. So if we've got this BSmart chat app, because I've noticed even people in rural areas have got smartphones, they are on social media, do you understand? So if they've got this app free of charge, they can actually click into the buddy system and have a peer support group, and this would help them to adhere to their treatment. It will assist with treatment compliance. It will also assist with the patient influx that will be coming in for less severe reasons, like because they've got questions or whatever. I think it would also help in creating reminders for patients, because sometimes we trace them too late, they default, and then it would still be time for us to reinitiate. And then when I'm busy with my stats, then I realize, oh, patient so-and-so hasn't come for their viral load, and they haven't come for their treatment in so long. And, you know, sometimes you find out now, by the time I literally get to trace this patient, it's too late. They've become resistant to treatment and they still die. And they've actually transmitted it to other people. So I think we need this app. We need
Brilliant.
it.
Thank you. Thank you very much for that. There's one question here by Olaitan Ola B. I think I want to, because this person has got their hands up. Where government's involvement is poor, how do we achieve this goal in government's hospitals?
Okay, in South Africa, like I mentioned, we've got NGOs. They work with government institutions. But unfortunately, there's only so much that they can do. Because you find that sometimes, I mean, I work in a very big hospital, it's an academic hospital. We literally even have an influx of patients coming in from Zimbabwe and Mozambique and Lesotho. So, I mean, we've got surrounding countries also coming into the country for assistance. And I mean, you can just imagine if they are bringing us 3 representatives and we are also short-staffed, we've hardly even reached the 50% mark in achieving any of our goals.
Brilliant, thank you.
Yeah.
No, that's very clear. Thank you for that, Musala. Thank you. Thank you very much for your presentation. That was fantastic. I think we need to press on because of the time. Thank you again. Our next speaker is Emmanuel Njamili. I think we can start. Emmanuel, do you want to start sharing your screen? So Emmanuel is an independent consultant and faculty at Rollins School of Public Health at Emory University. And he's going to be talking again on leveraging technologies to end inequality, end AIDS, and end epidemic. Emmanuel, the floor is yours. You can start sharing your screen.
Thank you, Erin. I hope that you can hear me very well.
Yes, we can hear you nice and loud and clear. We can see the screen as well.
Okay, great. And the presentation.
Yep, we can see it. Yep, perfect.
Okay, great. Thank you, Erin, for inviting me to speak on this webinar. It was great to hear from the previous speakers about how to leverage technology to end inequality, end AIDS, and end epidemic. I think that make my job a little bit easier. What I'm going to do is to maybe just give a little bit of, just remind ourselves what actually we are talking about when it comes to disease control, inequality, and ending epidemic. And then how we can actually consider what can we really consider as health technology. And then moving to then discuss how technology can be leveraged to address inequalities, which is a key for ending AIDS and HIV epidemics. When most of the time when we talk about disease control, is actually about controlling a disease by reducing the number of new infections, number of people currently infected, number of people who become sick, or number of people who actually die from the disease. This is actually done by implementation of various interventions for prevention, care, and treatment. And yes, we always have that goal to eradicate an epidemic, but that's definitely not something that is easy to do. In 1980, WHO declared smallpox eradicated, and this so far is the only infectious disease to achieve this distinction at the global level. One of the key reasons why it's so difficult to control epidemic and more importantly to eradicate is actually because of health inequalities. That's the difference in health status in the distribution of health resources between different population groups arising from the social condition in which people are born, grow, live, work, and age. It is unfair and can be reduced. There's a lot of intervention, there's a lot of ideas, a lot of solutions that really can be used to address health inequalities. But what is important is to understand that if health inequalities is what really help disease to propagate, and is also one of the key reasons why, if not addressed, we might not actually be able to reach the goal of ending the epidemic. A lot of the previous speakers actually spoke about when it comes to healthcare. It was quite interesting to hear a speaker mentioning that we focus on the quantity, but not really on the quality. So that gives me the opportunity to just mention here that when it comes to quality of care, we look at 10 very important dimensions: safety, technical performance, effectiveness, interpersonal relations, client-centeredness, continuity of services, access to services, physical infrastructures, efficiency and choice of services. All of these to make sure that we really can be able to address the 4 features of quality of care, and one of them being the ability to satisfy stated or implied health need of a community. This is very important to be able to reduce inequality. When it comes to HIV, we look at the projection that was set by the fast-tracked goal UNAIDS, and I will also look at what actually we have achieved so far. We see that if we were able to achieve the goal that was set, there will be 3.5 million fewer infections at this time in the world. So making this constant, what it is that we can consider as technology. WHO use a definition of technology as what you can see here is an application of organized knowledge and skills in the form of devices, medicines, vaccine procedures, and systems developed to solve a health problem and improve quality of life. In summary, technology can really be considered as, first of all, an intervention, a new intervention, or a new medical product. It can be a vaccine that can actually help to prevent a new disease, but it can also be everything that can actually help to improve service delivery of that intervention, or introducing that new product or vaccine into a population to address the spread of a disease. So let's then move to the programmatic consideration, which here really help us to understand the important need of technology to help us address the huge amount of data that is actually need for various stakeholders to address various questions. For us to have an effective program, we need to address a need when it comes to commodities and supplies, providers, infrastructures, people. On each of those stakeholders, we have different questions. To answer those questions, there are different types of data that need to be brought together. And all of this really need to be used in a comprehensive manner in order to plan to be able to provide adequate and effective and quality services to address the need of each population. But how can we set up a program without even considering knowing the coverage, understanding the unmet need, setting a target, and then design those sites so that the capacity of the site can actually be able to meet the target. And this means that we spend some money, and if we really want to be effective when we spend those resources, we then need to be able to collect data to understand how those resources are being spent at that site, which then lead us to ask ourselves the question, what are even the drivers of the unit cost? Between all of those important elements of programming, what are the one where we really need to focus if we want to be more efficient, if we want to be more productive? Then we collect input indicators, output, outcomes, and even information. We can conduct surveys to understand the impact of what we have already spent over years. Have we really achieved our objective, our target? When you you think at all of those data, how can you actually be able to bring them together into the single platform without the technology? So I think that gives us a good idea why having a technology that allows us to be able to do data analysis and present information, not data, in the form of a dashboard is really critical. Here is just a slide to remind us that it's very important for us to move from data to information to knowledge. Most people working at program level are not really data savvy folks. I bet they need information to be able to understand how to do what they are supposed to do. How can we make then these information available to them, maybe in the form of a dashboard? And that's the importance of also technology. Sometimes we focus on just looking on quantitative data, like we have circumcised X number of men, or we have X number of babies that was born HIV-free from HIV-positive mother. But why actually do we have this type of result? If you don't have qualitative information, it's difficult for us to actually understand why we see the quantitative result that we see. So it's very important to be able to bring together not just the quantitative data, but also the qualitative to actually have the full picture of the story. And coming to quality again, when we have the full picture of the story, then we can be able to look where we have gaps. We can be able to look at every single standard and being able to compare what we do related to those standards, identify then gaps that we have, and from those gaps, do a root cause analysis so that we can be able to then identify the intervention for improvement. And this is a cycle that we need to do continuously in order to really not just reach a high level of quality of care, but maintain it over time. And this cannot be able to be achieved without data. One of the reasons why most people don't pay attention to quality is because you have to manipulate so many quality indicators that is just impossible just to do it with an Excel sheet. So that's where technology can actually be able to help to really make this data analysis much more user-friendly and also make just the information directly available to program managers. Now, let me come back to HIV. This is just an example. Between 2000 and 2012, we are talking here about 12 years of VMMC, policy, strategy, advocacy, and program implementation. In 2000, there was this article in New York Times talking already about all the evidence that were existing, indicating that circumcised men were less likely to become infected than uncircumcised men. Nevertheless, it took 3 more randomized controlled trials that were done between 2000 and 2007 for WHO to be able to issue recommendation for countries in Eastern and Southern Africa to actually introduce and implement and scale up VMMC and additional HIV prevention intervention. And in 2016, you see this article that was written by former Minister of Health of South Africa, Botswana, and Swaziland, actually making a clear recommendation that VMMC is really a crucial weapon to fight and control HIV. But you see how many years it took to actually come to the point where stakeholders can be able to say, yes, we have a very important tool here. Let's make the best use of that. Why actually do we come to that? And we know that from the use of contraception and looking at the data from the WHO, it's very clear that anytime that you add a new choice, you also subsequently increase the coverage of those who actually protect themselves. And this is a very good example that we should use on HIV also. In 2016, at the UN high-level meeting, Dr. Anthony Fauci actually talked about that toolbox for ending HIV epidemic, mentioning VMMC, PrEP, and condoms. Just to mention that condoms is an intervention that existed since the beginning of the epidemic. And PrEP was just actually coming at that time as a new intervention. Well, now as it is in 2021, the target was set by 2020 to have 3 million people who have access to PrEP. Until now is only 1.5 million. So why is it that we actually realize that we have tools, we set targets, but we don't reach those targets? In addition, we also know already that is really what is going to help us to control the epidemic is to be able to have the right people getting tested. And when we identify those who are negative, actually to maximize the prevention effectiveness, really making good use of behavioral, structural, and biomedical prevention. And those who are positive, being able to trace through a contact tracing their positive contact and bring them effectively on ART, but not just initiating ART, but also trying to maintain them on ART. And then we realize that either for treatment or for prevention, that we need equally those behavioral, structural, and biomedical intervention to be able to increase adherence and retention and reach the goal of viral suppression. This need to also be taken into consideration the health system being integrated, but we have a clear framework for success here. We have a toolbox of very powerful intervention that have demonstrated effectiveness individually. And we know that if we bring them together, definitely we can be able to reach the UNAID fast track target to have 95% of people who know their status, 95% of those actually on ART, and 95% of those on ART actually viral suppressed, but also making sure that prevention is taken consideration and we take care of the need of adolescents and young women. And talking of adolescents and young women as a vulnerable population, this great initiative from PEPFAR, DREAMS, actually try to address the need of adolescent girls and young women by reducing their risk and vulnerabilities in order to actually empower them to be able to be much more protected against HIV. But when we look at this initiative that really rely on so many interventions that you need to bring together, implemented in various platforms, most of the time actually involving various sectors, then you realize the complexity of to be able to bring all of this together and the complexity to make effective all of the various referrals that the girls need to go from one platform to another one in order to receive the full package of services that will actually protect them.
Emmanuel, you've got 5 minutes, okay?
Okay. So how can we achieve this target and succeed on this great initiative, such as the DREAMS that I just mentioned, without technology? I just mentioned the adolescent girls and young women. If you look here, we need to actually be able to understand their risks and their vulnerabilities. And those risks and vulnerabilities actually differ from one city from another one, from one district to another one, from one province to another one. And that just give you the complexity of the quantity and quality of data that are needed. Looking at building on the lesson learned from PrEP, we also understand that data coming from the randomized control trial most of the time do not actually answer the questions that policymakers have to be able to decide on how to introduce a new intervention, how to fund it, and actually how to design the program for scale-up. Different stakeholders, funders, program implementers, users have so many different questions, and all of those questions need to be addressed individually, actually to make everyone feel comfortable to make those difficult decisions. And when it comes to users and providers, they also have so many questions that they want to be addressed for them to also make the necessary decisions. Then is really tell us that if you want to really succeed in introducing a new intervention and taking that intervention to scale, in addition to the randomized controlled trials that give us the evidence, we also need to be able to have the additional data that help address all of those questions that various stakeholders have. And this slide just gives us a summary of really what it looks like. First, we have on the clinical research side, different questions that need to be answered, different issues that need to be addressed. But when we have that being done, most of the time with a nice randomized control trial at the end of a long process, then we need regulatory approval, policy recommendation, cost, and each of those levels we need additional important data that most of the time the randomized control trial do not really give us. When we have that, we then need to plan for programming. How do we do that? We also have the different questions to be addressed. And finally, when the intervention, the service is available, the client, if you don't have the client, then we just burn resources and there's a huge waste of opportunity. The client will actually not come. So how can we actually give the necessary information to the client for them to make informed decision and actually adhere to those interventions that will protect them or to actually decrease the morbidity and the burden of the disease if they are already infected. So it's really tell us that it's never just about the product or the intervention. It's also, most importantly, the program. And for us to really get that, we need technology to bring all of those data into a single platform so that it can actually be used effectively. But most importantly, is always very important that all of this is really about the people. How do you meet the need of every single of these individuals in that community without actually knowing what they want? How do you actually know what they want without actually collecting those information and bring them into a nice digital platform? So this is just to conclude my presentation about really the importance of leveraging technology, which actually can help us to address health inequalities, which is critical if we really want to be able to control HIV epidemics and being able to end this epidemic in the next few years. Thank you, Erin, and thank you, everyone.
Thank you very much for that, Emmanuel. That was fantastic. Lots of valuable information here, covering a wide range of responses and interventions used for ending HIV/AIDS. So highly insightful. Thank you. I think we've got a good 10 to 15 minutes or so to have a Q&A session. We've got a fair number of questions unanswered. It would be nice if we can go through some of them as well. I think now is an opportunity for all our participants. You could unmute yourself, raise your hand and ask a question to Emmanuel, or including all the participants, well, including all the speakers as well. So do we have any questions?
Erin, can we remove the slide?
Yeah, sure. You can stop sharing if you want to, somewhere at the bottom. If you stop sharing. Then there has to be somewhere on the bottom right-hand side, a stop sharing button that you can just click on. Yep, that's it. It's all gone. Any questions from participants? Please raise your hand, and then you can unmute yourself. You don't have to type to ask a question. I mean, I've got one question to Emmanuel, just to kind of get to kickstart. Emmanuel, there's one slide that struck me the most, is the programmatic consideration slide, where you've got all the products, the providers, so the infrastructure and people, where they come together. And I think that's a powerful slide there, is to be able to bring all stakeholders together when you're solving a problem. But my question is, how well is this applied in practice? We know in theory it should work very well, but what about in practice?
In practice, when it comes to program implementation, and I think that it was Sinuko that actually spoke very well about that aspect. In practice is not often coordinated because you need different type of expertise to be able to address the need for supply chain, also address the need of human resources, then to be able to create demand, and more importantly, to actually be able to put in place the infrastructures. So you might end up having different type of implementers actually addressing those different parts of the program. So there you have the challenge of coordination, exchange of information between all of those players. And that lack of coordination by himself is already a great reason why program most of the time fail. You can also think that by having only one implementing partners, you actually address that lack of exchange of information, but that's not really true, because within that single implementing partner, the various people responsible of those different aspects, we actually might actually not even communicate one to another. We often see those creating demand coming to the site with the client and the service is not available. Just because someone did not actually ask the providers, are you going to be available that day? Or you have the providers available and the guy creating demand actually took his leave. Then imagine a technology that actually allows for a client booking, where, airline company does that. Just go on the website and you book your flight, and when you go to the airport, you meet the pilot and you meet the plane, and the plane is full, fuel is there, and you don't actually see a lack of coordination. Most of the time, not. You don't see that in the airline industry. It's because they use the concept of continuous quality improvement to continuously make sure that they address those issues and challenges. And that continuous quality improvement rely heavily on technology to actually bring all the information that all those various important players need to be able to make decisions and plan effectively their respective tasks, each of them on their various part of the program.
Brilliant. Thank you for that, Emmanuel. Clearly, there has to be a kind of a merge between the programmatic consideration and a relevant technology that could potentially back that up. Brilliant, thank you. Do we have any questions? We could move on to some of the questions that was asked at the beginning. Shola, there's a question here about the app. It says, apologies, I had issues joining on time. Is this smart idea, I think smart HIV solution, targeted at all people living with HIV?
Yes, this is an app supporting people living with HIV, but not in isolation of the support that they need in terms of social support with their friends and family, and also their healthcare professionals. So it's a support for HIV patients, or with the possibility to connect with peer support system and their medical providers.
Thank you, Shola. There's also another question here. It says, please tell us if you have advisors with you working in DR. Is this DR Democratic Republic?
Yeah, I think that's the Congo.
The Congo, I think, okay. I think this person's asking whether if we are working with anyone in Congo.
I always confuse both Congos, but we have somebody working in DR. I mean, we have a contact. We have contact in DRC in one of the NGOs, and they've looked at the app, evaluated it, and we might be taking those those collaboration forward. Yeah.
Okay, before we continue answering those unanswered questions, is there anyone who wants to raise their hand?
Yeah, I already.
Yeah, Marcella. Yeah, we've got Marcella who's raised her hand. Please.
I think there's one thing that, I don't know whether it's been swept under the carpet or it's not being regarded a priority. We initiate a lot of people on ARV treatment. I personally have lost count how many people I've initiated and re-initiated. But there has been this peer support group systems that they had at clinics, and the problem was, like, where would the groups meet, for example, because the facility did not accommodate a buddy system. And the other thing would be time. Who was going to lead it? Who was going to answer their questions? Who was going to, their concerns? Because now, unfortunately, in South Africa, I'm not going to speak for other countries, but in South Africa, we are now on a quantity versus quality. So I would literally be giving a patient treatment and I'd just be browsing through the side effects, what the treatment contains, and they'd literally have little time to ask me questions and understand the process that they're going to be going through with a virus that they need to live with for the rest of their lives. And that's how this default rate comes into being, because they experience a side effect. For example, patients that were on efavirenz, they were like, no, this thing was driving me crazy. I was hallucinating, so I just stopped, because like now I was behaving weirdly. I was seeing snakes, I was seeing ghosts, and I didn't get enough time to tell them, listen, once the drug settles into your system, the hallucinations will stop. Or like, I never had time, like during the consultation, to tell them that, or to tell them it's better to take it at night, or to understand that this particular patient, like me, might be a night shift worker and they might need to work around a different schedule. Because dolutegravir has only been introduced now. Like, they are busy healthcare professionals on dolutegravir, and there were misconceptions that it was causing a folic acid deficiency, and then there's another protocol that came out and said. So I think with this current app, if we've got an app, I mean, IT technicians can vouch for this. I did a bit of programming, just introductory. I mean, we have got console.writeline and console.read applications. So if somebody's on the buddy system and they're asking on the buddy system, they can get people that have been through what they're through with them, without literally finding a venue to meet, in the comfort of their own home, anonymously if need be. Do you understand? It also saves the clinician this high influx of patients that are coming for almost anything and everything in our already overpopulated facility. Do you understand? So it gives patient, clinician, and you know, it gets the community involved. Like somebody can join in as a buddy that I have a U equals U. I have a partner that's HIV positive. They can start advising people how they can continue conceiving, etc. Do you understand? So we need something like this because like we are in the middle of a healthcare crisis right now. And it cannot find us with a pandemic that's been existing for 10 years, not even properly implemented and managed. So like, we need our leaders on board. I invited so many of them. I hope this gets out. Like, we need this.
Thank you.
I like that. Actually, Marcella, I like the fact that how the technology could bridge the gap between quality and quantity here. I think that's the message that I'm getting here, but thank you for that. Thank you very much. I think we're now, is there any other last remarks, comments, contributions that anybody wants to make before we move towards closing the webinar? Any questions or anything at all? Okay, I think now we should gradually move towards closing the webinar. I mean, what I want to say is that, you know, hearing and learning from speakers and all the questions that's been asked by the attendees, there's clearly a need or an urgency for technologies to support all those involved in the management of care for people living with HIV, and more importantly, innovations that will empower. I think that word empower, empowering people living with HIV to help them take charge of their disease. And I really like the analogy just made by Marcella about this quality and quantity where technology could potentially bridge that gap. Another key message that I've got is from speakers is that we must find ways of strengthening and supporting the expansion of current interventions for the fight in HIV/AIDS, particularly with the objective of reducing stigma and discrimination, improving health outcomes. Joshua mentioned so much about, you know, preventing new infections. And I know in one of the slides, Marcella said overcrowded facilities. We need to find ways of establishing needs of HIV services and programs. So, and if we want to achieve these objectives, we really need to be smarter. We need such technologies at our disposal. So thank you very much, everyone, for that. We have a poll that we want to repeat, actually. What we did at the beginning, we want to repeat this at the end. Is just to see whether if your perception has changed. So to what extent do you agree that digital innovation is a need to support the fight against HIV/AIDS? I think if I can remember at the beginning, we had a 50% strongly agree and 50% agree. And I want to see whether if that has changed now. If we can spend about 15, 20 seconds on this also. I know it's 4 o'clock, we're just on time. Okay, so we've got 100% answered. Well, it's changed. 71% strongly agree and 63% strongly agree and 38% agree. That's wonderful. Thank you. So the perception has changed at the end of this 2 hours. And again, just before closing, I'd like to express my appreciation to all speakers for their valuable contribution. So thank you. My deepest gratitude goes to all who attended today's session and really helped it to make it very successful. So thank you very much for that. Okay, is there a last minute question here from Toba? I mean, we're very happy to take questions and comments or any contributions. You can always contact us via email. Okay. Maybe we might want to provide our email somewhere around here for anybody who wants to contact us and ask any further questions. So thank you very much. It's just bang on time, 4 o'clock. Okay, so that kind of brings the session.
Thank you, everyone. And yeah, on the 13th we have the demo at the African CDC conference. So you are invited.
Yep, maybe an email will be sent just to remind you guys. Thank you very much. And there's the email there which is provided. You might want to jot it down, info@bsmartdistricts.com. Please reach out if there's any questions, any unanswered questions. Thank you. Okay, thank you very much.
Bye, everyone.
Bye. Take care.
Bye-bye.